Good evening. Thank you so much for joining, and welcome to Weill Cornell Medicine's educational webinar series. Feel free to drop where you're joining from tonight in the chat. I think Dr. Mark and I are both in Manhattan, so that's where we're joining from. I'm Rebecca. I'm the digital marketing manager for the neurosurgery department at Weill Cornell, and I'm very excited to be moderating this webinar. Tonight, we're joined by Dr. Mark Souweidane for Turning Up the Heat, Laser Therapy for Pediatric Brain Tumors. You'll also see some QR codes on the slides. If you scan those with your phone, you'll be able to fill out a request an appointment leading to our pediatric neurosurgery department. So you can get some more information on Dr. Mark and pediatric neurosurgeons like him. So yeah, great. We can get started. Looks like we have a good group on the line. So let's dive in. I am so happy to welcome Dr. Mark Souweidane. Dr. Mark has dedicated his career to the surgical treatment of children with brain and spinal disorders. His talents as a surgeon are paralleled by the caring attitude and time commitment to patients and their families. In addition to the development of a world-class pediatric neurosurgery service, he has championed minimally invasive neurosurgery. Dr. Mark, going to turn it over to you. Any additional context you want to add?
Not at all, but thanks for rehashing the bio that I wrote. Thank you.
You are welcome.
But I just want to welcome everybody and thank Rebecca. Rebecca, as our digital marketing manager, has been with us for, I think, X number of months. She's an amazing. I'm sorry?
2 months.
2 months.
But
amazing addition already with full force, and the fact that she could pull this off in such a short term and get this highly professional. I can't thank you enough, Rebecca. Thank you.
Oh, thank you. That's very sweet.
So the intended aspect of this was not to teach neurosurgeons about laser therapy, but to raise the level of awareness, principally for those that might not be in the operating room day in and day out. When I was a resident, and I won't say what years, but when I was a resident at NYU, I remember laser had this aura of being something that was magical, and we always joked about how patients wanted it for their children to be treated. It was quite interesting. And then there was this big gap of nearly 20, 30 years where laser was kind of left by the wayside. It was a hassle to have it in the operating room. It wasn't a great documented advantage. And it wasn't until the advent that some of these devices were designed for implantation. And then MR technology allowed us to precisely monitor thermal energy in 3 dimensions in the operating room. And those two things have really moved us into a whole different sphere. And that's what I hope to present to the group today. The other reason for presenting this information is some of you, and again, we'll get a sense of who you are in one of the polling questions. But some of you sit at the gate from the standpoint of gatekeepers who see kids, refer these children. And it's really important to understand what's been evolving in neurosurgery, specifically in pediatric brain tumor management. So I love the globe. I'm looking at the attendees, mention where they're joining from, and this is a global audience without question. So we'll jump into the technology if you can forward to the next slide, Rebecca. I'll apologize in advance if any of the healthcare professionals or neurosurgeons, unless they're really hoping to get a dappling of the capability in pediatric brain tumors, because this intentionally is not going to be a technical talk. And so much so, Rebecca made me edit out a lot of the intraoperative photos and some of the stuff that I'm passionate about and I love to see. So we've intentionally made this more for a level of awareness. I showed this demonstration of a pre-op on the left, post-op MRI scan. This is a young infant, a couple of weeks of age, with a massive intracranial tumor, that dark area. I don't think I can use my pointer, but the dark area in the left hemisphere causing a lot of mass effect. This is exaggerated, but it's real. This is just a month ago. Then the post-op image on the right. The burden, or I should say the workhorse of what we do in pediatric neurosurgery is removing intracranial tumors. especially if one's career is focused on that. And the traditional mechanism for doing that is something called a craniotomy. In this particular case, there was probably a 12 centimeter bone flap that was raised, and we take out the tumor. It takes on the order of 3 or 4 hours, and by and large, it works and works really well. So accessible tumors that benefit from surgical excision is kind of our workhorse. And the next. And there's no hiding the fact that there's a huge benefit for the right tumor phenotype to take out the whole tumor. And this has been demonstrated time and time and time again. And this is a huge work that was generated by one of my colleagues that I trained with at NYU through one of the consortia in North America called the Children's Oncology Group. That for benign tumors, if you can get the whole tumor out, you can look at that, what we call that plot, that Kaplan-Meier plot. And at 10 years out, there's near 90% control rate, which is pretty phenomenal, with no adjuvant therapy, no radiation, no chemotherapy. So again, this is very dependent on the type of tumor, and this is limited to benign tumors that I'm showing you. But this type of graph and this separation between total removal or subtotal removal is replayed over and over again, whether or not it's a malignant tumor, benign tumor, and intermediate tumors. So the benefit of surgical excision has been, as I mentioned, demonstrated for decades, irrespective to some degree of the tumor type. There are some that don't, and there are some domains that surgeons aren't necessarily enthusiastic about going into. But by and large, the surgical extirpation of tumors is important for the longevity of that individual. Next slide. So the traditional approach toward this, as mentioned, is fairly traditional. In my training, some has changed, usually in the realm of image guidance, the sensitivity of imaging that we use. But by and large, a lot of the tools have been relatively static for decades. What has kind of influenced the risk in a beneficial way for most patients is a lot of the perioperative adjuncts that we have with better imaging, anesthesia, ICU care, some medication, seizure control, et cetera. But most craniotomies, traditional craniotomies, we're talking on the order of 3 to 7 days in the hospital. As I mentioned, craniotomy is that removal, that geometric removal of 4 to 8 centimeters of bone, put it back, and it does heal. And obviously, the bigger the tumor, the deeper the tumor, the longer the recovery. But the risk profile from those longer procedures, longer hospital stay do accumulate. If we go to the next slide, please. And so that image on the upper right, that's what's called an axial T2 image of the brain. That tumor in what's called the right temporal lobe, I'm going to make Rebecca point this out, but it's that bright area, on the right temporal lobe. Right temporal lobe, frontal poles, these are very, very easily accessed. So the expected risk for a benign tumor in this location is negligible, and it should be negligible, or else you shouldn't be advocating surgery. But these are easily accessible. The tumor in the bottom panel, circled in blue, I wouldn't say is impossible to access, but from traditional craniotomy and what's called microsurgical removal with certain devices we have, that's born with plenty of morbidity and probably not worth the effort, and certainly the morbidity that patient would pay. Left side of the brain, kind of deep central, what we call gray matter, near a lot of descending fibers that control motor function on the contralateral side. So a patient like this with a defined low-grade tumor has other options, as I've listed there: radiation, chemotherapy. You probably heard a lot about targeted therapy with molecularly defined agents, well tolerated. These are seldom curative. So not always temporizing, but usually meant to kind of hold the tumor at bay. And if not, the ill effects are not insignificant from radiation in the growing, developing brain, from chemotherapy from the standpoint of systemic toxicity. So that individual in the lower right panel doesn't have access to optimal therapy today. Optimal therapy being defined by take the whole tumor out. And that's been, as I mentioned, defined time and time again as the most beneficial method for low-grade tumors. So that's our alternative. And we have plenty of alternatives, but not as durable and certainly more risky. Go to the next slide, please, Rebecca. So Rebecca asked me to put in some polling questions. I did this intentionally to make it a little bit complicated because I would hope that at the end of the seminar today, you'll probably have some insight into some of these that I've used intentionally to kind of dupe the audience. So I'm going to give you should I just in a couple of minutes, or we go one by one?
Let's go one by one.
Okay, so
Let's
let's
see
start
the
with, thank you. All right, so laser therapy for brain tumors is completely non-invasive, meaning we're not making any skin incision, we're not going into the brain with anything, but it's all external, kind of like a MRI scan, if you want to think of it. True or false? Non-invasive. Anybody who wants to guess, or if you know.
Most people are saying false. Everyone's saying false.
So we've got an educated audience. I'm loving it.
Nice.
So it is not invasive. So it does involve some aspect of gaining some device, namely laser fiber, into the central part of the tumor or in the brain. Is it experimental or is it FDA approved? True or false? And I'll just say by way of an aside, FDA approval is a long, arduous process where it goes through the rigor of regulatory approval that says this has been demonstrated to have an advantage and it is safe. So it can go to manufacturing and it can be basically made accessible to anyone.
A couple of people are saying true, a couple of people are saying false.
Okay. The device is approved. The treatment or the application, and Chris is right, that it's approved for certain indications, but certainly there's a recommendation by a lot in the way of the oncology world that this is a recommended form of treatment. It's a good alternative. So yes, FDA approved, and these are devices that are accessible through industry today. Requires the use of an isotope. So an isotope is a molecule that emits radiation energy. These are used in medicine a lot, either through systemic delivery or otherwise. But these have, to some degree, some potential for injury, bystander effect. These are hot isotopes. And if anybody's ever had any experience with some of these, lead shielding, isolation, etc.
Did you say hot isotopes?
Yeah, isotopes that emit energy.
Oh, okay. Got it.
You're loving this, aren't you?
Everyone is saying false. Yeah, that's why I'm here. I'm here to learn.
Okay. They're all right. There is no external energy source. This is purely thermal. So and radioisotopes can injure cells, but through a different mechanism. So this is purely thermal or hyperthermic energy through a laser fiber. You can only use it for tumors that are less than 2 centimeters in diameter. Is it limited in its capacity? Okay, so far,
True, false, a mix.
yeah, and it's leaning a little bit toward false, which is the correct answer. And I'll get into this in the detail. So hyperthermia can be used to treat any lesion in the brain, but there is a threshold beyond which we start to worry about byproducts and risk. So you can burn a 5 centimeter in diameter tumor, but that's going to mean that you're going to have swelling and inflammation. And we're going to talk about that a little bit more. So it's not governed by the size of the tumor. Doing laser as a resident and a fellow junior faculty, everybody knew I would have to wear eye protection when we're using laser. There had to be shielding of windows. Patients had to have eye protection. So laser interstitial thermal therapy in the brain requires eye protection, true or false?
So far, we've got a mix.
Yeah. Okay, again, because the laser is embedded in the parenchyma of the brain and it's inducing thermal energy, there is no scatter of light. So everything's contained within a closed arena, if you will. So no eye protection is needed, like the conventional, what we call external sources of a laser that we would use in a handheld probe. So don't need eye protection. So the occupational
for a regular surgery, are you wearing eye protection?
Different type of eye protection. That's against splatter.
Yeah. Oh, okay. Got it. Yep.
Okay. All right. If we can go to the next slide. Great. Yep. Thanks everybody who participated.
Yes. Thank you, everyone.
and how it works. So in brief, the beauty of this somewhat is perceived or real from the patient's standpoint. A 10 to 12 millimeters is probably even bigger than most incisions we're using, maybe half a centimeter. These are tiny incisions relative to a craniotomy incision. In an English scale, we're talking about a quarter inch maybe for most of these incisions. We do insert a laser fiber through a small, what we call twist drill in the bone. And these are on the order of 3 to 6 millimeters, tiny. It requires MR targeting, MR basically interface. So once the laser probe is in place, we have to have MR as a controlling mechanism to see what we're doing once we turn the laser on. And then you get this real-time feedback from the standpoint of what temperature is the tissue, and it gives you a overlay of what you're doing from the standpoint of time and temperature thresholds. And that's how we dictate whether or not we're killing cells or just increasing the temperature, et cetera, reversible, irreversible injury. So pretty phenomenal technology. And if you go to the next slide, I think we have a depiction of what that looks like. So that that cutaway in the middle panel is a laser probe. And the ones that I'm typically using today are about 3 to 4 millimeters in diameter. They're pretty darn small. And you can see that the detail within there is quite a technological feat. You have to have a coolant so that everything down the shaft of the laser is not getting burned. You have sometimes what's called a directional fiber. It's a red cone that you can turn, usually with a robot, to go in a 360-degree radius. And then if you look at the panel on the left, this is kind of a bird's eye view or an aerial view of what the suite looks like. So the patient's actually in an MR magnet. We're outside in a controlling unit at a desk with computer interfaces doing things like dropping the fiber probe in further through a robot, turning the fiber, applying energy, shutting off energy, redirecting the laser. And that panel on the right from one of our industry partners, you can see what it looks like as a see-through. And that the only violation of the skin is that small incision, and the rest is kind of held by a robotic interface. So as close as you can get to doing remote neurosurgery yet for taking out tumors. And you could conceivably do this remotely if the probe is put in. So go to the next slide, please. So, let's jump into the application in children. I'll just say that as a pediatric neurosurgeon, I usually suffer from needing to adopt principles, technologies, interfaces from our adult colleagues. Not that kids aren't as important, but the types of demands, the type of monetary, financial input in research and development doesn't lend itself to doing that in an exploratory realm in children as much as it does adults. So we do ride on the coattails of what our adult colleagues have done with adult patients. Also, that's governed by the sheer number and the demand and the potential return on the investment for industry. So there's been a lot that's been in the adult world, in the world of what's called functional neurosurgery for ablating certain lesions in the brain that cause things like tremor that you've probably heard about. There's a lot that's been done in metastatic tumor, which is a very rare phenomenon in children. We see this a lot in adult oncology patients. And then some of the malignancies in adults. In children, our focus isn't always, but there's a disproportionate number of kids with low-grade tumors versus the adult population. So going back to that original premise that I was talking about, is the value of surgery becomes really tantamount. So retrospective means we've done this procedure, what does the results show? And can we dig out of the medical record kind of whether or not it was tolerated or not? So there have been some very robust, what's called registries, where you pool that data from different institutions. Most of these have been governed through industry to help with their approval process. You can read some of those bullet points on the left. I'll just say in short that the tolerance has been good, and that quote unquote complication rate, if you look at the next bullet down, the overwhelming majorities, 8 out of 10, are temporary. And that has to do with transient swelling around the area of hyperthermia. So it's like a bruise. If you hit something or cause a burn, you've all done this probably in the oven or on the stove, where over time it starts to contract, but that acute period of time for the next several hours or even a day, there's a lot of swelling and blistering going on. Same thing in the brain. And the effectiveness in controlling disease, and we're looking at a plot of kids with low-grade tumors treated with laser-induced or laser interstitial thermal therapy, or LIT is the acronym. If you get what's called an EOA, or estimate of ablation, the higher that goes, the more likely, logically, you're going to control that tumor, right? So if you only treat 50% of it, unlikely it's going to be curative. If you treat 100% of it, more likely you're going to see a long-term control rate. So that's all kind of intuitive, but been borne out in fairly large registries. You go to the next slide. So as mentioned before, they're not regulatory and they're not government, but the National Comprehensive Cancer Network is something that helps provide in cancer care in the United States recommendations for optimal therapy, or I should say therapeutic options. And I don't know what year this was published, but you can read it. It might be considered for patients who are poor surgical candidates, right? So those that have deep-seated tumors, those that have tumors that are inaccessible. So already this really well-versed group of individuals have been laying out claims as far as whether or not it should be presented as a therapeutic options in certain situations. And the next slide, please. So this is kind of a real-time depiction of how it works. And if you look at the first MRI scan on the left, there's a small white dot, and we see these all the time in pediatric neurosurgery. Patients get MRI scans for needing growth hormone, or they fell off their bike, or they had a seizure. And, at least once a week, I'm seeing individuals with what do we call incidental lesions. The question always is it a early diagnosis of a brain tumor that has yet to blossom and grow and present with symptoms? The beauty of these incidental lesions is they're small. They're easily treated with laser, and they're usually deep. So in this particular instance and example, you can see that MR. And ignoring the next MRI scan, if you look at the panel on the left where you see this animation of these yellow and blue lines, these are called thermal lines. And we're doing this in intervals of 3 seconds of measuring temperature in 3 dimensions. And we can see the tumor. Maybe you can imagine it's that white spot in the middle center panel, where we want to get that threshold of X number of minutes, X temperature, to make sure that we kill those cells in that domain. So we're doing this in 3 dimensions. We're doing it in nearly real time and different views. So it's quite elegant. And then that middle MRI scan shows a lesion after laser. I think I said 3 months. And that bright rim you're seeing around that dark, it looks like a target, is injury from the thermal energy. So we've achieved our goal when we go beyond what we can see in the resolution of MRI scan. And then it starts to contract over years. This patient's now over 5 years out, and it's continued to contract, but you're always going to see a little bit of a thumbprint. So small lesion, larger ablation field, most likely going to be a cure. By the way, when we do the laser deployment, we also have the ability to take a specimen of the tumor at the time so we can confirm what type of tumor it is. A lot to be learned. So if you go to the next, please. This is, what I think in pediatric neurosurgery, this is kind of exciting. This is a child who was diagnosed with what was called Lee-Fromini syndrome. This is a choroid plexus carcinoma. And the box that says diagnosis, this is treacherous from the standpoint of neurosurgeons going after these. These are highly vascular, usually in very young individuals. And the most meaningful aspect of someone's long-term outcome is getting the whole tumor out. That was done and done very well. And that patient survived. They got adjuvant therapy. In Lee-Fromini, as other cancer predisposition syndromes, most of these individuals have a ticking time clock. That cancers come at a fairly high rate. So they get a lot of surveillance imaging. And even though you can successfully treat individual tumors, there's always the fear that something else is going to come up. 8 months post-treatment, you start to see a small little tiny dot in front of the left frontal horn. And then the prediction in seeing incidental lesions and leukemia, other cancer predisposition syndromes, is nearly 100% of these lesions are going to turn malignant. So we've adopted this kind of initiative at Memorial and the group that I work with as far as this idea about intercepting these tumors before they become malignant. And that's what we did in this individual. And you can do the math. 52 months after treatment with no malignant transformation is pretty profound in this population. So if you go to the next slide, I think we have, this is that individual. So he's now, I think, somewhere about 5 years out. And this is X number of weeks after treatment. And most of these admissions, most of these treatments, they're going home the next day by and large, which is a phenomenal shift from what we traditionally do in neurosurgery, going after tumors with craniotomy. The mother has given us permission to use this. He's got a more recent video, again, in a pool. He loves swimming. But it's a big undertaking from the standpoint of the technology, but a huge impact. If you go to the next slide, we're particularly interested in pediatrics and using these types of technologies because we know that external beam radiation therapy, which is one of our tools and our armamentarium against pediatric brain tumors, specifically malignancies, has certain injuries that are predictable from the acute aspect of radiation toxicity. But another is radiation, as crazy as it sounds, is very mutagenic, means it damages DNA, which predisposes individuals to cancer. So nothing's more frustrating than to see cancer survivors in childhood come back 10, 20 years later with a rip-roaring malignancy in their brain that you can't treat. So the avoidance of radiation therapy, especially in the cancer predisposition population, and I mentioned leukemia as one of those examples, is a big, big reach, and that has potentially big impact. So in that example, I showed you this idea about using something that, insofar as we know, is not mutagenic to treat some of these tumors and those that we know are destined to get cancers with further mutagenic treatments. Is a huge, interesting arena that hasn't been explored to a great degree, but we're aggressively going after that population for good reason. So we're excited about that. The next slide, please. So takeaways. Rebecca asked me to, she might have authored this, I can't remember, but it is safe. There's no question. The safety aspect of this is based on great patient selection, knowing what you should or should not be doing, being aware of where it is that you're treating relative to the potential side effects, being ready from the standpoint of certain agents we have to reduce swelling, keeping them in an ICU setting, et cetera. But careful patient selection will, by and large, avoid most forms of risk associated with the procedure. And there's no kidding around that when we place probes in the brain, there's always the risk that you get a catastrophic hemorrhage. But I'll say that in hundreds and hundreds of documented manuscripts with regard to laser, that is, very, very infrequent, single-digit percentages or less effective. As I mentioned, if it's a phenotype that you can treat, and it's not one of these invasive malignancies, and you can get good tumor coverage, the prediction is you're going to get a 100% cure. Just what we've seen with traditional surgery. Minimal impact, I mentioned, one night hospitalization versus 4, 5, 7 is pretty profound. And at the end of the day, who's going to argue with a 7-day hospitalization if it's curative, right? But from the standpoint of economics, from the standpoint of self-perception, psychosocial issues, getting somebody home and getting them out of a hospital setting, no question, is going to lessen morbidity. And mentioned most of this is now backed by evolving really good publications. Next slide, please. So we're very excited. I'm very excited that so I've authored this multi-center study through what's called the Pediatric Brain Tumor Consortium. You can see the centers there. This is a huge, large-scale effort to really test this idea that we can cure small tumors in deep, inaccessible regions with laser. So I showed you some results from a registry. The beauty of this is it's what we call prospective. So there's very rigid enrollment criteria. There is extremely solid validation principles about definition of control rates. We're going to couple this with tumor phenotype, not just low grade and otherwise, but there's a lot of different low grades. So when a parent comes and they've got a biopsy that shows that their tumor or their child's tumor can be targeted, which treatment is better? We're not going to do a head-to-head comparison, but wouldn't it be nice if we said that at 3 years, we can tell you that there's a 95% control rate of your child's tumor with laser versus sometimes 2, 3, 5, 7 years of oral therapy and something that's not curative. So we're looking forward to it. We've got great partnership through the PBTC, and we just had our last call with the FDA last week. So if we go to the next slide. And then the last thing I'll say is in this evolving trend of less invasive treatment for brain tumors, this is a technology that we're actively embracing. We have a platform in the laboratory, but there's a fully operational system as well in our clinical facility for adults. And this is very specific, again, for movement disorders. It's being explored in very, very limited basis for children with tumors. And anything we're talking about with hyperthermia, it can be used to basically increase drug delivery or kill tumor cells, what's called ablation, just like laser. Same thing with this. The beauty of this is it's non-invasive. So there is no drilling of anything. It's entirely external to the skull. What we are doing and what we've drafted is a pilot study to look at this technology instead of the laser, even though we've got this full-on scale or this full-scale study with laser to treat low-grade tumors. We're going to open up a pilot study for using high-frequency magnetic-guided or MR-guided focused ultrasound for these same type of tumors. So can we do this safely? Can we encompass the whole tumor with an external non-invasive method? So it's hope that with appropriate funding and regulatory support, we'll have this on the launch pad. We already have the draft of that pilot study under review. So hopefully looking forward to furthering this even into a whole nother realm. And I think probably the last slide, if you move forward, Rebecca. So there's a time for a Q&A. Go ahead, take it up.
Yeah,
Take it over.
so we've got a few minutes for Q&A. A question we got in the chat is an intersecting laser needed to determine the depth? I would imagine they mean the depth of going into the brain.
So just if I can, maybe I didn't go into it in great detail, but we've spent a lot of time preoperatively in surgical planning interfaces. So there are software interfaces that when we have a lesion, we know, again, with millimeter scaling, where that lesion is external to the head. Whether we're using a robot or other devices, these are all governed by what's called navigation. So MR is basically dictating where we're putting that probe. And it's pretty rare that we're off by a millimeter, maybe 2 millimeters at most. So we know ahead of time the depth of what we're doing, and then we watch that in real time. In certain devices, we can implant these laser fibers 1 centimeters, 10 centimeters, 2 centimeters from target, get an interval MRI scan. Do we like the trajectory or not? So you have the option of changing. And I'm proud to say that in my series at Memorial, I don't think we've ever had to redirect. So the precision is really nearly magical. It's pretty precise.
Incredible.
Yeah.
And then another question. How about the side effects one usually observes with surgery, like TBI? And see, I'm not sure what TBI is, but I imagine
Yeah.
you.
Yeah. So traumatic brain injury.
Okay, that makes sense. Yep.
Yeah. So we can control to a great degree what we call that burn margin is and how large it is in 3 dimensions. It's really the byproduct is extremely well controlled. We're not really affecting much at all in the way, at least as we can tell on MR, the resolution of MR, any normal cells. So obviously we're getting into the finer points of microscopic invasion, but basically there isn't that byproduct of large anatomical regions that are being injured either by the path of the laser or the hyperthermia itself.
Great.
I can read the next question. Do you always perform a biopsy before laser? Yeah. The short answer is yes, but it's not a mandate. And studies that have looked at combined versus not combined morbidity. So, are you increasing the risk by doing a biopsy? Short answer has been no. But I think it's always prudent, and certainly in our clinical trial that we've evolved and designed, we're always going to do a biopsy because if we don't know truly that that was a low-grade tumor, then we can't make any statements about the control rate. And in addition, if for whatever reason laser was ineffectual, tumor was growing back, you have that pathology at hand and ready to go for adjuvant therapy. So yes, we always perform a biopsy.
Great. And then a question we got in the Q&A, how should we prepare our child for the procedure? I imagine there are ways that you talk about it differently with children. So
Mm-hmm.
emotionally, and what do you need to do in the days leading up?
Yeah, I love that question because that has nothing to do with laser and a lot to do with just getting, no, I mean this, getting a child through an ordeal
Yeah,
which is
absolutely.
unfathomable to any of us and emotionally
Yeah.
gut-wrenching, really for the parents. Any of us who have children, want them to be emotionally stable and fear erased from their minds. And they walk into these interfaces we have in the clinic and then get rolled into an operating room, and you can only imagine. So yeah, listen, it's an art form. It depends on the child, depends on their level of aptitude, their age, the relationship they have with their parents. I take great pride in spending an immense amount of time with children and trying to engage them, not in decision making, but in the process that's going to happen. And I freely use language like, you're not going to die. You're not going to wake up in the middle of this procedure. Your parents are going to be in the hospital the whole time. I mean, reassurance, 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 normalcy as much as you can do it. But, I'll say in the same breath, 30 years of doing this, what amazing diagnosis to treatment and just really mature in a very accelerated way.
Yeah, that's incredible.
Yeah.
Um, Great. And then I think we have one more question in the chat. Can laser therapy be used on DMG spinal tumors?
Short answer is no.
Okay.
So DMG, diffuse midline glioma, malignant tumors, highly invasive. I will say that it's being explored in DMG in the supratentorial or infratentorial compartment, brainstem or thalamus, as a means for enhancing drug delivery. So you're not going to the threshold of ablation. So you're keeping that temperature somewhat modest in the hopes of systemic drug delivery being enhanced. So that's the place that's being explored in some of these highly invasive tumors. But the problem with DMG and a lot of these malignancies is you don't have that clear demarcation and you don't have that relatively small constrained volume where you can use ablation to kill the tumor. They're too intertwined with the same reason we can't use traditional surgery in DMG successfully. So the short answer is no for ablation, potentially in the brainstem and the supratentorial compartment for drug delivery. Spinal cord not explored thus far.
Incredible. Well, that is all the time we have. If you did
Can I say
not get
one
a
last
chance,
thing before we log
yes,
off?
please,
I saw
please.
that, yeah, Mr. Michael was one of our attendees, and I just want to stress to the group that work like this is never made possible without engaging individuals who are generous and gift giving. He's been phenomenal. I actually hold the Michael Chair at Weill Cornell, based on the generosity of his family. But influencing thought, innovation, creativity. I can't say enough about those individuals and the Michaels family for helping support initiatives like this. So I saw him logged on and I was just tickled by it. So thank you.
Incredible.
Go ahead, Rebecca. I'm sorry.
Oh, no, and thank you, for pointing that out. Well, thank you to everyone for coming. Truly appreciate it. We will be sending out the recorded webinar to the email you registered with. And if you want to get in touch with our incredible doctors at the Pediatric Neurosurgery program at Weill Cornell Medicine, you can reach out via phone, email. The QR code, as I said before, leads straight to our request an appointment page. And Dr. Mark, thank you. I feel like I learned so much, loved working with you, truly such a pleasure. And everyone have an incredible night.
Yeah, it was a great pleasure, and thanks for everybody who attended globally. It's impressive. Thank you.
Yes.